Thank you, Seb, and thank you to the Congress President and Professor Lustig for the warm welcome. It's always a highlight of the year for me, and you're a close, very close friend of us, and we really appreciate that. As Professor Lustig mentioned, I'm going to talk about revision total knee arthroplasty for arthrofibrosis with some flavor of the impact of the patella and looking at the etiology and surgical treatment options. By means of disclosure, I do have an individual product development agreement with Stryker. So we say, why are we talking about arthrofibrosis at all, particularly in a conference that focuses mostly around the patella? Well, when we looked at the Mayo Clinic reoperations of patients that we operated on, we found that 50% of the reasons that we had a reoperation was for limitations in motion, whether it's a lysis of adhesion, open or arthroscopic, or revision knee surgery for that. And this continues despite advances in surgical technique, implant design, and pain control, with the incidence being about 4%, and 50% of the people who become stiff require a secondary procedure. The diagnosis can either be acute or chronic arthrofibrosis, and the etiologies are either intrinsic to the knee or extrinsic to the knee. And I will highlight to you that I've got a strong focus on the host variation. That is what makes you and I different from each other. Similar to our hair, our eye color, there's an underlying genetic host variation difference for patients that contributes to limited motion. The extrinsic causes we know are numerous. I highlight one that I feel is very important. It's evaluation of the hip, and that's why I still get a long leg x-ray on every patient prior to knee surgery. Intrinsic, there are multiple causes, but one of the main causes is infection, and we've heard it multiple times this morning as well. And for all patients who are stiff, such as this patient who ended up presenting with an infected knee, I evaluate them for infection. Now let's get to the crux of what can contribute to arthrofibrosis in these patients. The surgical factors include component malalignment, which will place the patella and extensor mechanism under rest. Overstuffing the patellofemoral compartment, as we've seen this morning, contributes to limited motion. Joint line elevation can contribute to arthrofibrosis. Inappropriate removal of the posterior osteophytes. Increased condylar offset, this patient has a malunion, and poor pain control can all contribute to causes of stiffness after knee replacement. In my hands, this is how I think about revision for total knee for stiffness. Number one, I want a wide surgical exposure that includes a medial release around the tibia, a wide synovectomy, plus minus a quadriceps nip, occasionally the need in severe arthrofibrosis with an arc of motion of less than 10 degrees to release the collaterals, utilize a hinged knee construct, and occasionally the use of a tibial tubercle osteotomy. Removing the polyethylene will be helpful, whether it's modular metal-backed, monoblock, or an all-polyethylene tibial component. For the femoral component, it's important to remove the osteophytes, peel the posterior capsule, correct condylar offset, correct the distal femoral resection, and correct malalignment. The tibial components, such as this patient here, may often have issues such as being debonded, having malalignment issues, and removing it to balance both flexion and extension. And some of these patients, as I mentioned to you earlier, do require the release of the collateral ligaments and a hinged knee construct just to get into the knee safely without an extensor mechanism disruption and to help facilitate their motion. But even with all of this, the literature has reported very modest gains in range of motion for patients who develop arthrofibrosis. So I want to spend just 2 or 3 minutes here highlighting what I think the future of knee surgery, particularly for this problem of stiffness, will lie. And that's in a stepwise approach that looks at large numbers of patients, identifies what genes and genetic profiles put people at risk, testing it in animal models, and then having pharmacologic interventions to prevent and treat arthrofibrosis. And this is what my lab is focused on for the last 15 years. So what we've done is we've taken large numbers of patients that we say have normal motion, 0 to 110, 120, age, sex, diagnosis, and implant match them to patients who have had total knee replacements at Mayo Clinic, have become stiff, and we take their blood, 10 cc's, and we take tissue from the revision knee arthroplasty and look at whole exome sequencing, and we look at the local inflammatory response and compare these patients. And we've been able to classify, this is a Manhattan plot, looks like the Manhattan skyline, 13 genes and 17 singular nucleotide polymorphisms that contribute to arthrofibrosis. And the importance of this is to highlight it's just not the mechanics and the patient selection, but the individual genetic response to the knee replacement that we do. And we've identified 5 pathways. I'm not going to go over them, but the 5 different pathways that you can see here, including the uric acid cycle, the Wnt pathway involved in bone formation, prostaglandin synthesis, and the JAK-STAT pathway that are particularly involved in our knee patients that develop arthrofibrosis. Then we've created an animal model in which we've tested these hypotheses, and this Mayo model of contractures is a rabbit model in which we give them stiffness. We look at the cellular impact on these fibroblastic cell lines, and we've mapped out the genetic expression profile, showing that most of these genetic changes occur within the first 24 to 48 hours after surgery. And finally, and the step I'm most excited about, is translating this back into the clinical practice for our patients. We've been testing celecoxib or Celebrex in vivo and in vitro, placing these in collagen-loaded sponges within the knee and releasing these drugs with special sponges that can release them at the time of knee replacement for 2 to 3 weeks to prevent stiffness. And we've also placed these sponges to evaluate their impact on cartilage and the synovium, and have shown that the collagen has been safe even if you're not going to resurface the patella. So in summary, arthrofibrosis is a debilitating complication. There are a variety of factors that play into it. Revision knee arthroplasty only helps these patients by about 30 degrees, and I believe that really the genetic variation and looking at the inflammation will be the key to solve this problem. Thank you very much.